Hello, everyone. This is Mike. Continue our discussion on management of diabetes in pregnancy, a clinical update. Today's topic is antepartum care. First, let's talk about nutritional therapy. Nutritional therapy is widely recommended as an integral part of treatment of GDM. Unfortunately, relatively little information from controlled trial exists to guide nutritional recommendations for the condition. In general, nutritional requirements are the same for pregnant women with or without GDM. However, several dietary modifications can lower glucose levels more effectively than a standard diet for pregnant women. These include reducing caloric intake for overweight and obese women, for example, to approximately 25 kilocalories per kilogram of body weight, limiting carbohydrate content to 35 to 40% of total calories, and focusing on complex rather than simple carbohydrates. A second of this modification has been shown to improve perinatal outcomes compared with higher carbohydrate diets. These principles can be applied in practice by individualizing dietary advice under the guidance of a nutritionist who is expert in dietary management of women with diabetes mellitus pregnancy. Now, how do we identify women at risk? The next step after initiating nutritional therapy is the identification of women who need additional treatment to minimize the risk of perinatal complications. Two general approaches have been applied in this regard. The most common approach employs regular glucose self-monitoring by patients. The optimal timing and frequency of monitoring has not been determined. One study that is often cited as proof that post-meal glucose targets are more important than pre-meal targets in the management of GDM actually compared relatively low post-meal targets to relatively high pre-meal targets. Thus, the design was biased in favor of post-meal monitoring. Other studies have found fasting glucose level to be more closely related to perinatal complications than post-challenge glucose levels on the diagnostic OGTT. In the absence of definitive evidence, it has become common practice to ask patients to measure capillary glucose levels before breakfast and 1 to 2 hours after breakfast, lunch, and dinner. Treatment targets have varied among studies that have demonstrated improved perinatal outcomes. Some commonly recommended targets are fasting glucose of less than or equal to 5.3 millimoles per liter, 1 hour post-meal glucose of less than or equal to 7.8 millimoles per liter, and 2-hour post-meal glucose of 6.7 millimoles per liter. The other general approach to identifying pregnancies that can benefit from intensified metabolic management employs a combination of maternal glucose measurements and fetal morphological measurements. This approach is based on two principles. The first is that certain fasting plasma glucose concentrations measurable at routine clinic visits are high enough to warrant intensified treatment because they impart a high risk of preventable perinatal complications. Studies by the authors group suggest a fasting plasma glucose level greater than or equal to 5.8 millimoles per liter is useful in this regard. The second principle is that among women with lower fasting glucose levels than this, fetal measurements can identify a relatively large fraction of pregnancies that will not incur a perinatal complication in the absence of intensified treatment. The authors group has used fetal abdominal circumference measurements obtained by ultrasonography to identify such pregnancies. In the presence of a fasting plasma glucose level of less than 5.8 millimoles per liter, a fetal abdominal circumference below the 70th percentile for gestational age between 29 to 33 weeks of gestation was associated with no excess risk of large for gestational age infants or cesarean deliveries compared with non-diabetic pregnancies. Moreover, the findings showed that intensified insulin treatment in pregnancies with fetal abdominal circumference above the 70th percentile could eliminate the excess of large for gestational age infants. The capillary glucose targets employed in the last sub were fasting of less than 4.4 millimoles per liter and 2-hour postprandial of less than 6.1 millimoles per liter. The lower target can be used because there is virtually no risk of creating small for gestational age infants when treatment is directed at fetuses with evidence of increased growth. Note that only women who were placed on insulin require glucose self-monitoring with this approach, providing considerable savings to offset the cost of the fetal ultrasound. Let's discuss intensifying treatment beyond nutritional therapy. Several options are available for intensifying therapy beyond nutritional management once a decision is made to do so. Traditionally, exogenous insulin was the primary mode of pharmacological treatment. Insulin remains an important option, and regimens should be tailored to meet glycemic targets. No convincing evidence exists to exclude any available insulin from use during pregnancy. Small studies have suggested that regular aerobic exercise can reduce glucose levels as effectively as insulin can. However, the intensity of exercise employed in these studies was high. For example, 60% of maximal oxygen uptake for 45 minutes 3 days a week, and not easy for the women to achieve. Regular exercise of lower intensity, such as walking after meals, is often recommended for women with GDM, although data are lacking on the effect of the level of exercise on pregnancy outcomes. Two randomized clinical trials have expanded the pharmacological options for GDM to include oral antidiabetic agents. Langer et al. Compared glyburide with insulin in women who were deemed in need of intensified treatment on the basis of maternal self-monitoring glucose level results. They reported equivalent perinatal outcomes in the two groups. Only 4% of women assigned to glyburide received insulin to meet pre-specified glycemic targets. Rowan et al. Conducted a similar study but compared metformin with insulin. Perinatal outcomes were similar to the two treatment groups. 46% of women assigned to metformin received supplemental insulin to achieve glycemic targets. Patients report preference for metformin over insulin. At least two oral agents can therefore be used to intensify treatment and achieve good perinatal outcome. Longer-term information on offspring outcome is available from Rowan et al., who found similar body fat content at age 2 years in offspring of the two treatment groups. As noted above, offspring of mothers assigned to receive metformin had skin-fold evidence of increased subcutaneous fat, which raises the untested possibility that adipose tissue in other locations could be reduced. Information regarding the effects of these agents, which may cross the human placenta, on truly long-term health of offspring are lacking at the present time. Let's summarize what we learned about antepartum care. First, medical nutritional therapy is recommended for all patients based on principles: reduced caloric intake for overweight and obese women, limited carbohydrate intake, and a focus on complex carbohydrate that are supported by a small amount of good quality evidence. Second, maternal glucose self-monitoring, or a combination of fetal abdominal circumference measurements with fasting plasma glucose measurements in clinic, can be used to identify women who may benefit from intensified treatment, or conversely, those who do not need intensification. Third, insulin, glyburide, and metformin are viable options for intensification of treatment in the high-risk groups. And lastly, regular exercise is often recommended, but the benefits for pregnancy outcome are largely unknown. This ends our discussion on antepartum care. See you next time when we discuss glycemic targets in pregnancy.